Thank you. So, this is Senate Appropriations and it's February 14th, Valentine's Day. And, we're starting our testimony on the FY 2025 budget with, the Department of Vermont Health Access. And so we have a document that we'll run through and, glad to have you here. Good to always see you, particularly, having Stephanie back even for a little while. So,
Welcome home.
yeah.
Patty Stromolo, our acting commissioner, is online with us.
I see. Okay, so who's testifying?
I'm going to testify. Alicia Cooper is here. She has laryngitis.
Oh, okay. Uh-huh.
But there's a few things at the end which probably are more in Alicia's wheelhouse.
Okay, so Addie's here, but just more as backup then, or, all
Or
right,
if we have questions on particular.
so then we'll start with you, Stephanie. It sounds like you're the designated presenter.
I am today.
All right.
So we'll start with the DEVA administration budget, which some of it's going to be very repetitive with what you heard in budget adjustment. But the first item is the staffing budget. And there are several changes in the staffing budget that are, you see typically across every department, the rollout of salary benefit changes, which include the pay act rollout and any internal adjustments, RFRs that have happened or are wrapped up in these adjustments. And so you see there's salaries, it's a $1.2 million gross, 1.23
And
million.
retirement, Stephanie, retirement.
Yes, retirement.
Oh.
Is part of the benefits pieces as well. That was it. Big bill. Several years ago. So salary benefits, which include retirement and healthcare and any other changes on benefit side. The new pieces, the child care assessment, which will kick in come July for the state as an employer. And also the family medical leave initiative, which is on the state employee side. Those assessments are included. There's a handful of temporary positions in DEVA, which have not previously been budgeted for. There, 2 of them are long-term care and 3 of them in rate setting or vice versa, that are reflected here, and 1 other technical position. We have other temp positions that we shouldn't budget for because they just fill in, but these are the ones that are, we'll have to find another, if we didn't have this work being done by then, we'd have to find another way to have that work being done. And then we have another significant change, and that is that we have a projected lower vacancy from what was the vacancy when the FY 23 budget was originally built. So we have had greater success in recruitment and retention.
What is current vacancy rate?
So this is reflecting a vacancy rate that's down around 3%.
3.
Yeah.
Well, that's very low.
Yeah.
That's just about full because.
Yeah.
Okay.
And so that's the baseline of the subtotal staffing changes. And then we have a few net neutral moves that are happening, where the policy unit will be moving up to the central office. And then the 3 quality positions, as you may recall from the conference committee last year in the budget bill that you added into the central office, have moved down to us. They moved down to us. Those positions were transferred down mid-year to us, and 2 of them have been filled. And then what you see here is the money permanently moving into DEVA's budget for those quality positions.
Okay.
Well, have you presented as gross and general fund?
Because we're Medicaid, so the total dollar amounts are the combination of state funds and federal funds. For most administrative activities, we get a 50-50 match. For certain ones related to advanced planning documents, directives, we get a higher match.
So could I think of it as federal in general?
Yeah.
So you're thinking of it as total, and the general can share of that total, and so the difference would be the federal.
Okay.
But that's the traditional way that we've always presented the budget.
But not everybody.
But not everyone's Medicaid funded.
Right. But even, I guess maybe some people put Medicaid or federal there.
Some people probably do. Yeah.
Well, and the other thing, because it's administration, this is not going through the global commitment washing machine,
Right.
so, that's the other difference here.
Yeah.
Okay, so,
So that's our staffing budget, and then our operating budgets and our internal service funds have a modest down. But they're mostly driven by the directors from finance and management on what those funds will be adjusted, given our current projections. And the other down that's in our operating budget is there are operating expenses that go with the policy unit moving up to the central office.
how many positions?
So there are 9 positions in the policy unit. The dollars you see here essentially reflect 7 because 2 of the positions are HCBS funded at this point.
But when you trade $1 and get 2, you're actually losing money by that downgrade then.
Oh, no, it's just switching, it's just taking it out, it's
This
gonna appear in a
budget,
different.
we're taking it out of this budget, we're giving it to Tracy.
It's still gonna be, still gonna
You'll see it, yeah, you'll see the exact same opposite, or you did yesterday. Move. And then.
Could you, the quality positions, can you give us a description of that job function? What are those quality positions? What are their, duties? They're not a quality control, in the sense of QC for determining the accuracy of your eligibility processing, or are they?
They are not, they're in our, in another division, and I'll get you the descriptions for them. I'm sorry, I don't have them.
Okay, I was just wondering,
If Sandy were with us, she would chime right in.
all right, let's keep
But we'll-
page 2. That's page 46, but.
Well, yeah, if you had. It is page 2.
I do have it right here.
Here.
And there is a copy for the entire committee, if any of you want to have some nighttime reading. But it'll tell you everything you want to know in terms of what we're paying for the eligible services, to MCO investments, to federal poverty levels that are used in different categories, different definitions. It really is quite a reference book, so. All right, we'll keep going to a technical adjustment.
On the contracts side of our admin budget, and this is a pretty much identical to the budget investment. So it's the same general fund up, it's the same driver, that we ended 23 underwater in our contracts. Needing help to come in to close 23, pushing some stuff out to 23 on the general fund side. It's an unusual presentation here because we actually know that our federal fund appropriation amount was too high, and we're bringing that down, but we're bringing our general fund amount up. So in total, we're down, but it is a general fund increase for the needs for across our whole array of contracts.
75 to 90 contracts.
Agreements.
Yeah.
And then we have a small amount of grants go out through the admin budget, they're mostly the Blueprint grant related, not the pieces that go through MMIS, but there's a series of grants. And we need a technical adjustment to the federal fund spending authority in the grant line, in the admin budget. And so that gives you the total picture of our changes in the admin budget, which are even more granular on the ups and downs on the first appropriation for FIBA. So, no questions, we'll jump right into the big program
I hate
budget.
to say, but this isn't exactly riveting yet.
No, it's not.
I don't need to. Well, no, I'm just looking around at the table. I mean, people are just on the edge of their seats here. All right, now we're down to.
Now we're down into the program budget. And so the first item in the NEMA budget is the caseload and utilization change. And that's through the consensus process, and it reflects.
And these are big bucks. Look at this figure.
Yeah. These reflect the what was adopted at the emergency board for FY 25 for the caseload and PMPM, the DEVA portion of it. And it is a significant down, and it's mostly being driven by the fully annualized. We'll be through the unwinding at the, by the first quarter of the of FY 25, we believe fully through the unwinding. And so this reflects basically a fully annualized year of the step down in our caseload. So it's mostly caseload driven. There are a few areas in that consensus process where we did see some PM increases, but overall, it's a caseload driven reduction. It's across mainly in the global commitment line item, but there are the pharmacy program, the CSR program, those are the ones that are going up. Those are in our state only. A portion of it's in our state only. And then we have a small amount in our non-waiver, which is our chip related caseload.
Yes,
So,
you have a question?
You know,
No,
not, well, I'll ask.
no, I thought you
Well, no.
switched, but maybe you didn't.
Well, thank you for watching my twitch, but I will ask. So why in the overall do we think, is this?
Oh,
Because we didn't do eligibility determinations for 3 years.
Yes.
yeah, and you'll note,
Is it all the eligibility?
that is, it's what
It's
we
all
see.
of that.
It's all of that.
Okay.
And what you see if you are a nerd on the Medicaid budget is that the general fund portion of it is lower than what you would expect. Because most of the down is in the new adults without kids, which, you know, we do see down across most of the adult categories and a little bit of down in the kids, but what's driving this is the new adults, the childless new adults, which have a high match, which means when they go down and their cost goes up, we don't harvest as much general fund. So even though we have a $53 million gross down, we don't have
What
a
match
20.
rate are you using? Because your match rate is changing.
So the match rate for new adults, childless new adults is 90-10. And then the everything else is on the underlying base
I
match
know,
rate.
but
except for
that's
the chip.
gone up a little bit, so
That's
I'm just wondering in your
So that's,
calculation.
the baseline match change is not in our budget. The baseline match change is in Tracy's budget. So that's,
Okay, all right.
yeah. So this is the caseload utilization piece and the calculation based on what that projected caseload.
And the projected caseload will be in our big book, so we would know.
It's in the big book and it's in the adopted emergency board motion.
Yeah. Senator Burns.
So in the report, the big book, that maybe is where I get the answer to my question. I just wondered how many people with that dollar number, when we started doing the redetermination after COVID, how many people lost coverages?
So, looking if Addie wants to step
Sure.
into,
Yeah, I'm happy to chime in. Hi, it's Addie Stremolo, Acting Commissioner at DEVA. We do official reporting on enrollment totals on a quarterly basis to account for things like claims lag and retroactivity. So as of the last official report, it was about 10,000 Vermonters fewer in our overall caseload since beginning the redeterminations. It's going to end up being more than that, but that was as of this fall.
What do we, not to get into a big healthcare policy discussion, but what happens to those?
Some moved out of state, some are already getting insured and don't even respond.
and we do have a slight tick up in the QHP on the exchange.
Right, but that would be the main thing for a Vermonter to do, would go to the exchange.
So 3 years is a long time for no redetermination, so we probably have people that were on Medicaid, but also having employer-sponsored insurance
Right.
at the same time.
Yeah.
And what's encouraging when you see we see the movement in where you'd expect it. You're not seeing it in duals and those types of populations as much. You see it in the adult populations and a little bit in the children's population.
so I figure out 3,300 a year for 3 years. Which makes it sound better.
Yeah, but that, thank you.
Going on to item number 6, is the current Medicare buy-in and MSP programs that we fund. And this was in the budget adjustment at the partial year amount, and this is the fully annualized estimate of the impact of the rate increases that came through in January for Medicaid buying the dual eligibles into Medicare, covering their premiums, and then the current structure for the Medicare savings plans that we have. So this is not, doesn't reflect the desire of the House to expand the Medicare savings programs.
I think that bill also may be a variation in Senator Lyons' committee. It comes with well, if you did all of it, it's a very significant price tag, it's like 40 million, maybe, don't think big. But, there's a group that really, when they turn 65 and go into Medicare, their benefit cliff is very, very significant compared to what they were getting prior to, their age change, so, there are different variations on how much you wanna buy that down. And the advantage, of course, to eligibility workers is it gets rid of applied income, which are basically, if your income is above that standard dollar for dollar, you have to use that up toward medical care, and then Medicaid would pick up. So it's it really is a forgotten group of people until now, sort of like AABD in some regards. So I don't know what will happen with that. I just know as we're looking at our 25 budget, our 25 budget overall is extremely difficult. I will put it that way. And so any added new is
The House is looking at this.
well, they won't have any more money than anybody else, I know. So,
They just got more limit on their credit card over there.
well, a lot's gonna depend on what we do with housing, emergency housing, because that's millions of dollars there that wouldn't be available to assist this group. So it's turns out to be kind of a zero-sum game, but we'll keep going. So obviously,
So it's a clawback, we don't have really any control over that, it's all general fund.
so your
The new one.
caseload and utilization changes actually help fund your ups here between
They
6
do.
and 7.
They do. It's a little bit of mixed metaphor because the caseload utilization, the big part of it is up, the match of that is up in Tracy's budget. So, and so clawback is the new, the estimate from FFIS with the increase, for, this is the portion that the states pay for the Medicare Part D. For the savings they essentially would have had under their dual population. Number 8 was also in the budget adjustment. This is just a move from the health department to us on the family planning services being paid out through MMIS. So your next budget, you'll see the opposite down in that budget. The safety net investments are also just a net neutral internal move to DIVA out of the goal commitment and down into the non-waiver area, I think. 10, it was also in the budget adjustment. This is a fully annualized breast pump supply cost. We weren't in compliance with the recommendations. We were covering the breast pumps, but not the baggies, essentially. 11 is the fully annualized version, fully annualized amount of the MEI adjustment for the QHCs and the RHCs. So
That we did in the VA.
you did the VAI starting January, so this is the, for the entirety of the.
One thing that would be very helpful, and we had the House asked for it, and that was a study on doing cost-based reimbursements for FQHCs. And it would take a few millions of dollars to move that way. There's no recommendation. But in a letter, they're arguing that our reimbursement methodology is not in compliance with federal law. The agency has taken a different position, and I'm just wondering but that's only been oral. Is there some kind of
There
written?
was a letter, I thought it was sent by Alex to you, because we knew I think it was a memo to address to Senator Lyons, but we'll make sure that you have it.
All right.
We were aware that you would ask for that. And
On which?
On the at QHC, the
Yeah, I think there
methodology
is
we
one.
use,
I-
and so.
Well, maybe it got into health and welfare, but,
Okay.
I just, if I could have a copy.
We'll make sure you get one.
Because obviously there's a difference of opinion.
And that, yeah.
Either way, they'd like more.
Yeah.
We did, it wouldn't clarify.
Yeah.
But, okay. Hospice rates,
This is bringing the hospice rates up to the floor essentially that we have to be in compliance with. So this is fully annualized. And number 13 is the same issue that you saw in the budget adjustment. This is the page, it doesn't increase under the alternative payment model that we pay the retreat under now. It doesn't change the total amount of that. What it does is who we're seeing being served at the retreat. It determines which funding source they come from, and so if they're a forensic patient assigned by the court, or if they're staying 60, if their stay is longer than 60 days, then their whole stay has to be paid for with general fund dollars. It can't be matched under Medicaid. And so this is an adjustment to reflect what we're seeing as the mix of patients being served at the retreat. So it's less on what it reflects is a higher number on the forensic and longer term stay folk than it does on the global commitment.
and it's coming out of the budget, not mental health.
Since it is entirely paid out of the DEVA budget. I mean, the parts of the agreement about services and how the patients are, who's coming in is Department of Mental Health, but we're the fiscal administrator of it.
Center staff.
Do you negotiate a contract with Brattleboro to get this rate, or, cause that's.
So we do annually have a contract with the retreat around a set amount of beds per day at a given rate. And we go through that. It's based on a calendar year. But how we fund that, what sources of funding we can use for that depends on the actual patients they serve. And that's what you're seeing here. Is that we're not changing anything about the rate, we're not going up or down in the rate, but we are changing the funding need within our budget because of who our past experience was showing we were being served. So that
So,
is a truing up
yeah.
of the funding sources, not.
Oh,
Okay, what is, this is maybe a little bit different, but, the rates that we're paying the retreat versus what we're paying the Vermont Psychiatric Hospital.
I think they're fairly close. We have checked on that. We might be a little bit higher still at the retreat. The Vermont Psychiatric Care Hospital has had and DMH is much better to speak to this, but the operations there have been constrained by staffing. And so it's a little bit harder to make the comparison right now, I think, or it was a short while ago.
Well, they had a lot of contract nurses that, added cost. I was just wondering, setting.
But it does get looked at.
Yeah.
before you go to the next one, could I ask, the hospice rate, is that changing?
It's going up. We have to meet a minimum. We have to pay the guidelines from the federal guidelines suggest that it shouldn't be below a certain level, and we are.
And we did that.
We did a budget
Yeah.
adjustment.
We already.
Started in January, we brought them up to the level they need to be at. And then this what you see there is
The
the
annual.
value, the value of that for the whole year, of state fiscal year 25.
Yeah.
And you will see it again next January if that rate recommendation goes up again.
So, on the MEI adjustment, we had to do that. When we did the budget adjustment, we pulled out just about all the.
Yep.
Ops because, the 25 budget, more you obligate ahead, the less flexibility you have to deal, and the governor was using the same money for his budget, and the House was using that same dollars for the one-time list, and we just pulled it. So, there was a rate proposal that got changed for visiting nurses. We had a brief discussion, about that. And, that's something that this we had to do, and the other is something that we have a choice about doing. And so we've just put it into the 25 discussion because FQICs would like more money. I'm sure every medical provider would like more money. There's no additional increase, even though the match rate, we're making it up for VAs, SSAs, all the host of providers are all level funded. That's quite a. Would they like to have a 20% increase? Or 24 even. Does the department have a position? You obviously don't have that rate increase here in your 25 budget.
We do not have.
You do not. Let's keep going then. We're on to 14.
Number 14, the Children's Personal Care Service Program is in the DEVA budget. And that's we're paying the child care assessment, which will turn on in July, for the piece for this program where the families hire and that's paid through.
Does that go through ARIS?
Yes,
These
that's the
payments
payroll.
going through ARIS.
And so instead of having it impact the client's service package, we're picking up the cost of it here. As a line item.
This is our childcare payroll.
Yeah.
All right, GME.
GME, our calculation for what GME what we can pay in GME has gone up. And so that's what's reflected here is a $7.1 million gross increase. The funding for that comes directly from the university. The match funding for that comes directly from the university. So there isn't a general fund impact. And in the budget book is a 2-pager that lays out the components of the GME program, and the contract that's in place, the piece of the agreement that's in place for this year. It's not in the House committee. There was a little bit of confusion that the GME program works like our sort of education. In the same way, our graduate medical education that we do through the commerce bills normally, that it's per person, like it's to defray costs because of the teaching hospital at various levels. And so it just, for clarity, we wanted to include.
This is more institutional based as opposed to individual student based.
Yes.
Okay, 16.
16 is a increase to their border hospitals that we're putting in place in 25.
But is a border hospital in Vermont or outside?
Within 10 miles.
So is Dartmouth the border hospital and is Southwest Vermont Medical Center a border hospital?
So this is within the board. So these are not in-state hospitals.
Out of state. I need to start to just a minute.
It's hot within 10 miles.
New York, Massachusetts, New Hampshire. The Schuman's in that.
Must be from that, true. I gotta be a
Question.
You ever go to bed from medical care?
Southwest is in.
It is in Vermont. It is in Vermont.
every year waiting.
Southwestern Vermont Hospital.
Sometimes it's in Vermont.
But it's also affiliated with Dartmouth.
17
Yeah.
is a new item. And I think you talked about this a little bit yesterday with the.
Yeah.
the
Oh, this
secretary.
is Bennington again?
Well, this is
Well,
actually the retreat.
No, this is not
This
the
is
retreat. This
Brattleboro.
is the retreat. I keep mixing them up.
Number 17.
Bennington and Brattleboro. This is
There's
Brattleboro.
17, Bennington 17.
No,
I mean-
psychiatric residential treatment is.
PRTF
Is Brattleboro retreat
they were
and 15 beds.
15 beds. This is a partial year estimate. So just fair warning, there's a high likelihood you might see this in budget adjustment depending on how the rollout happens for this program. We're much like the other part of the retreat. We're the financial administrator of the program. But the scope and the programmatic setting of the program is best directed to DMH and DCF.
How do we come up with that rate?
What for the residential treatment?
So this is just an estimate, the actual agreement has yet to be executed. And the rates have yet to be set. It's our best estimate of what a cost for the year could be, but it's a squishy.
So as I got this now, it's $474,270 per person,
How much?
Per bed.
per bed. 474,000 per bed.
Well, that's not quite as much as the psychiatric hospital.
No, it's lower than the psychiatric hospital. But this is also, just to be clear, it's not fully annualized yet either.
Why analyze it? I
Annualized,
doubled it.
oh, you did, oh, okay.
Oh, you did, you annualized it.
Well, I mean, based on your
Okay.
numbers, and I just wondered how 475,000 per bed sounds.
Now,
It is below the psych hospital and the,
I'd bring a bed for that.
I bet you would.
let me ask, Stephanie, children have been going to the retreat right now.
Mhm.
And I guess DMH has been paying. I'm just wondering, how does this facility relate to what is already in place at the retreat?
so DMH and DCF
All right.
are gonna be your best answer
All
for
right.
that. But there, it's a very specific scope of work in a very specified, area where Medicaid will match, for the services for the kids, for these types of services for kids that are eligible for those services, medically necessary.
Yeah, okay. And I don't know, maybe some kids are at the retreat that are not actually in the custody of any of the state agencies.
There could be that.
Oh, all right, we'll have some more discussion then with the other two departments. One-time appropriation, and this is,
This is the global payment program. We talked a little bit about this during budget adjustment because we are internally, with the private independent care practices, primary care practices, we started this in January for them. This is money, one-time money to cover the tail of claims, when we move to, hopefully 4 to 5 hospitals will
yeah.
participate in this.
Been doing a global budget.
A global budget, so the size, what we're paying them now in fee for service, we will convert to a prospective payment, and so they'll have 2 prospective payments, the one under the current ACO program, and then this prospective payment, the 2 together, making it global.
How will that relate to the 5 hospital participation in the ahead model for?
So this is a state pilot that is meant to give us some give us some testing ability,
Yeah.
understanding what it might mean to the hospital, mean to us, our ability to do the
So-
financial calculations, how our testing our actuary models around it.
Well, what I'm trying to understand is you're saying we're making the payments to One Care
For the attributed lives that are at One Care for
for the,
services that are paid for through that, for the total cost of care there, yeah.
right. Would we continue to make those payments in addition?
Yeah,
to
so that
global?
wouldn't change at all, and this is just the piece that would pick up the non-attributed lives, the pieces that are not through the current, that are still paid fee for service through the Medicaid program. And that's what this calculation is based on.
So these are costs that right now are outside the One Care
Yes,
payment.
and so for example, the duals, I think that was a question from yesterday as well. The fee for service payments that we make for duals that are Medicaid payments will be part of this for those hospitals, should they volunteer to be part of it.
So we don't have a 5 hospital yet.
We have an estimate of what.
Yeah.
Some expression of interest. I should
Yeah.
say. All right, so this is, ups and downs and so forth. So what's your total budget?
Total budget,
Guess that would be on this sheet.
this is on the last page of that sheet. Total budget, 1.176 billion. It's down a little from 23. Because of that highlighting. But yeah, so it's on the bigger side.
Yeah, I'd say so.
Well, we must be one of the biggest insurers in the state.
One of the big three.
Also, we have a lot of adverse selection.
You do.
And this,
Slightly different profile of
but this
services. in
does
some
not
years.
include the nursing home
No, the
and the
nursing.
long-term care.
Right,
pieces
so
that are in the
this is,
jail
yeah,
budget,
so
so.
Medicaid in total, Tracy can tell you, this is a $2 billion operation. We're a little over half of it. A lot through mental health, a lot through Dale.
Quite different than when Elmo Sansarosi operated the Medicaid program out of his desk drawer. Yeah, Senator Starr.
Yeah, I'm wondering, on this third page,
Sure.
Dr. Dinosaur, it's got brackets around that.
The 190 down.
Yeah, what is,
So this is actually a labeling issue. This is the immigrant health program. This is the we called it Dr. Dinosaur expansion, so.
But it's all general fund.
It's all general fund, and the reason you see it down is because when you passed that initiative, you had a $1.4 million budget, and we kept that flat line until the program became mature. And we are seeing,
Not quite this amount
not quite that level, we're not maturing at that level, so we're bringing it down a little bit.
based on actual.
Based on 2.5 years of experience with
so it
it.
doesn't have anything to do with.
No, it's a change from what is budgeted. These are all incremental changes from what was budgeted in 23. That's in the ups and downs. Or,
Is that true?
Other questions? A lot of money.
and then I know, because I said this to the other committees, there is a piece of language in the government recommended language package around state recoveries, Medicaid state recoveries. That I know Addie has had a conversation with Jen Harvey about. It's an issue that's come up where there was change around noticing and filing claims on states and timing at the probate court that has created an issue in terms of we are required to seek, we're supposed to seek an
This
estate
would have to
recovery.
do with the able accounts that.
It's separate from that, it's
related.
a Vermont probate. But the issue came up, the language that's in the budget bill language is related to the change in the probate court, and the able accounts was a separate issue.
But I
Similar.
thought we were doing both
So you,
in the budget itself.
yeah, we did not have language around the able accounts in the proposed language, that came in on the, I think on the House side.
And we pulled it out.
And you pulled it out, so you'll have.
Oh, they
two
pulled it out.
They pulled it out on the floor, and so you'll have two pieces of Medicaid estate recovery policy to discuss.
So, the estate recovery.
Yeah.
Of a long-term care population,
Yeah, generally, if they receive long-term care services.
but I don't ever remember we did a lot of estate.
We
recovery.
don't, it's just, it's a.
If you
A
look
limit
at,
came in to say that any entity can only have 1 year to file a claim against an estate. And so what we've had since that change has come is if the estate waits beyond that, 1 year from the date of death. And so if the estate runs the clock on that, essentially, then we as a state can't file, but we're required to, we're in a sort of
you're required to, but state law prevents it.
yeah, and so it's trying to reconcile that we're.
But, so the able accounts, did you look at that language?
I have not, I can circle back with that.
All right, we need
I
to,
know,
we need
so
to.
you need a recommendation or a.
Yeah, because,
weigh in on that.
well, the treasurer's office,
Yeah.
has proposed that,
Yeah.
those accounts not be subject to estate recovery.
Yeah.
And,
What are they?
well, they're, accounts that allow you, I believe, to support employment and to save money. And I'm done.
It's an acronym, Able.
Yeah. It
Yeah.
is,
But
forget.
I wouldn't think those would be the population that would be in long-term care, so I'm having a hard time. Because if it's to allow you to save and, et cetera. If you're in a nursing home and we're taking every dime you've got except,
Wow.
$35 or whatever it is now for personal needs. I was just. What is the problem here? Do you know what the problem is, Tracy?
No, we'll move
right.
on.
So you need to look at that language that was originally and got pulled out on the floor, by the House. I talked to the treasurer's staff and said, we'll pull it, but there's another, that you had this other,
We
related,
we had
estate
put forward
issue.
this language,
And so, we need to look at both of them at the same time.
and they're, in all, neither one of them is,
But
Any
the
significant amount
transfer
of
of
money,
assets and all that, how would anybody have anything to recover from?
I think. It's, there's a handful of them that we do have, there is an asset in the estate and. It's probably usually
How would you even know about it?
because someone would be filing an estate and probate, would be opening an estate and probate with the, that's what the rub is that if they do that after the year. Then we've had several probate courts say no because of the change a few years ago.
Alright, well,
Does Diva have attorneys that do that probate work?
No, it's the attorney general.
They do it. It's Able as the better life experience, but achieving a better life experience is what that
That's
means.
exactly good, thank you.
but I thought it was really for people to, because there are, incentives for people who might be on social security disability to maintain
That's what I thought.
Medicaid and so you gotta have income to put into that account, and it's like if you're in a nursing home, it just doesn't fit, so that's why I don't understand why Medicaid would be going after an Able account.
I will.
I don't
I don't
You
know
don't
if
need
you
to
do.
respond, that's my question. That's my question, to please look at what the treasurer's office was recommending. It would make sense for them, because obviously it's work for them to go back and whatever. On the other hand, if it's something that we have to do, it's like, but I just can't figure out who in the world would be subject to long-term care estate recovery that would have an Able account. But, I'll let you take it from there.
They could have started it when they were younger.
Well, maybe,
Just started though,
it hasn't been in,
yeah,
3 years.
2014 is passed federally.
Yeah, but we took a little while to, in Vermont. All right, thank you. Other questions that we might have? Well, I would, do you have does the department have a position on S-109? It's doula, and it would add another service for Medicaid to cover and reimburse. Have you done a cost analysis, and do you have a position on it while you're here? And I don't expect you to answer
Right.
exactly.
I can answer it.
Well, has Medicaid got a position on it?
Yes.
Oh.
Yeah, they can have it through in the MMIS by January 1, 25.
But what's the cost?
There's a port of, I'll have to get the fiscal on that for you, get the information out for you. Have it like that.
There is a fiscal note on it.
Nolan has a fiscal note on it.
Well, if it's a fiscal note, there's
And
a
then
cost.
we also have Medicaid information, I think. Oh, fuck, you want me to look it up now?
I think our position is if it's funded, we will implement it.
Yeah.
All right, but the question is, how much money is it, and do we have any money to fund a new, coverage? That's gonna be,
Well, we're
ultimate.
one of a few states that don't currently fund doulas through Medicaid.
That's
I'm not-
today or tomorrow?
I'm just gonna find it.
That's on our agenda for today.
No, it's on right now at 2:45. I figured I was taking advantage
Oh,
of
it's
it.
2:30, it's not quite 2:30, so I was gonna pull up stuff.
I've got I've got it right here. Joint fiscal's done, an estimate.
Yes, that's it.
And it could be
But
year
there's no,
one.
there's no cost in the bill right now because of the Sunrise study that the OPR is doing. That would be available for action next session. So OPR predicts that it will cost about, I think, $15,000 is what they said for the Sunrise study. And then, once they have that.
Why would they do a sunrise? Because to see if it's a
For
regulated,
certification,
Up to,
only for certification purposes, and they're gonna.
and whether they
talk
should be
about-
subject to, regulation.
Right now, doulas are regulated by a certification process. Could be a registration process, could be licensure, so as we were looking at it, we were thinking of certification based on some of the national organizations. So OPR said the best way to do this is to do a sunrise. They're doing that. The results won't be in until January 2025, or for discussion during the next session. At which time then the legislature will make a decision about how they are regulated through registration, licensure, or certification.
And then we would decide whether we want.
Then the decision is, but what we heard from Medicaid is that there was some enthusiasm about it. But that they could have it put in as a profession into the MMIS by January 2025. So,
But still, you
yeah, no,
can do all that mechanically, but you gotta have the money to pay it.
then if you're gonna do it, then if you're gonna cover it, that would be something that would have to happen during the next session.
Right. So, OPR is gonna be in here wanting 25,000 for sunrise.
They, OPR, so what we heard from we didn't hear it from OPR, but we've heard it. I don't know how we've heard it, but OPR has had a significant number of compacts, agreements. The result is that they've lost a lot of money on licenses.
I know.
And so this is like a straw on the camel's back. I think any one of the things, and we've got, I think, one or two more compacts coming to us from the House.
Which
Which
means
will reduce,
social workers one.
yes, and the occupational therapists. So that'll be another reduction, should it pass, that they pass, it'll be another reduction for OPR, which will mean, they need more money. But for the doula, the benefits.
We're doing 209 now.
Yes, we are.
Can I talk about the benefits going on?
you're gonna stay for.
No, we can go into it a little bit more, but as I understand it, what you have, and we have a bill here. That probably carries an appropriation of 25,000 for the OPR to do a sunrise service.
Only on the top of Mount Mansfield, let me.
Oh my God. I've got a company coming for Easter. I must be on my mind. The sunrise review. And then that would inform next year. The issue isn't the mechanics or Medicaid being able to pay the claim. The question is, do we want to expand the service? What would be the price tag? And that's a decision that's gonna be made next year.
Yes, but also it needs to be balanced by the cost savings that occur as a result of the doula care. Pre and postpartum, and so
Oh,
this.
Senator Lyons, what chair before me said, there's so much social calculus in this room. You know,
This
so
is.
you're saying if we pay.
Reduction of cesarean sections,
Uh-huh.
reduced depression, postpartum depression. So there are a lot of national studies and other studies that indicate
Well, what about post BAA depression?
that we've all got that.
All right, all right. So, Stephanie, I think, and Addie's still on the line, and I think, You should probably, if you have anything more, or you can't add because you can't talk. So,
And she's a lucky one.
so I'm gonna suggest, that we, let our folks from Diva, leave, and we will take a brief break, and, then we can come back to 109, and the question is, do we move it out favorably? With a $25,000 appropriation to fund the Sunrise Review. And then whoever's sitting around the table a year from now will then determine, what appropriation would have to be made, which looks like it might be a little more than 100,000. It's 15?
Fiscal
Okay,
impact,
15, oh, 50, all right.
Instead of-
just say 10,000.
Oh,
Good
sorry. Yeah. But, according to Center Alliance, if we invest in this, we're gonna get at least a 21 return, so Medicaid would be able to, probably increase reimbursement to FQHCs. Or,
Like $20,000.
by
We
some,
get so much
huge
money
amount.
back, we'll need to
Okay.
buy our own.
Well,
all right,
That's
so,
already
I'm going to, take a break, we'll go off live and come back in 15 minutes. And we'll just crank through some more, ending up with a, Department of Health budget where